There are many ways a person can sustain a spinal cord injury. With
Thank you, Professor.
we discussed last week, we mentioned this last week that when until we can rule out spinal cord injury, it is assumed in every head injury patient. So, anyone with a head trauma, we assume that they have spinal cord injury, and it always is vice versa. So if we suspect someone has spinal cord injury, then we also assume they may have sustained head injury, unless we have ruled that out already. So there's many ways to injure it. We have trauma, which can be from blunt force or penetrating force traumas. Falls, typically car accidents. We kind of discussed plegia and paresis already last week, okay, for stroke. So same thing here, paraplegia is lower body paralysis. Tetraplegia, also known as quadriplegia, is from the neck down. So it really depends on the level of spinal cord injury. Which level? Is it cervical? If it's cervical, well, what number in the cervical column? Okay, so we have 7 cervical, 12 thoracic, right? 5 sacral. How many lumbar? No, 7. Whatever the number is. So we have a table that will help you distinguish what the patient's limitations are. We have a couple questions on that on the exam on what the patient's limitation will be after sustaining a certain level of spinal cord injury. Okay, we'll get to that later. Manifestations again will be depending on the level of spinal cord injury, whether it's cervical, thoracic, lumbar, or sacral. We will not test this chart because this is talking about certain syndromes. So we got central cord, anterior cord. We're not going into that detail. So we can skip chart 63-7. Okay, we do have a table which we will test. I'll just skip these because these are going to be explained in the table anyway. Okay, this table right here, 63-3. So we'll go to that for the signs and symptoms. For diagnostic purposes, it'll be the same as with head injuries. So it's and stroke. So it'll be a CT or an MRI of the spine. Let's do emergency management. So what will guide us with emergency? It's always ABC, right? So airway, breathing, and then circulation. So after you ensure airway and breathing, then you and circulation, meaning you stop any obvious bleeding, if any, because again, most common cause of these is trauma. Then once you take care of the important stuff, then you immobilize the spine. Okay, so we start with a rigid neck collar. So that will prevent further displacement or injury to the spine. So here are a few suggestions at the scene of the injury. So this is before EMTs come. So you try to keep the neck neutral as much as possible, avoid movement. Of course, if the patient is in a place wherein it's really dangerous, let's say they're right at the edge of the subway platform, of course, you won't let them fall. Okay, so you would move them to safety and then immobilize the spine. All right, so here is the level of, let me finish the emergency first. So until EMTs come, the patient should not be moved. Keep them in as a unit. You know, if you need to turn them as a unit. We call that log rolling. Okay. What else are included in spinal precautions? Because this is not new. So we immobilize the cervical spine by putting in a rigid collar, turning the patient as a unit. What else would institute spinal precautions? Can we raise the head of the bed? Why not? Because that means they're no longer they're no longer straight. You're now bending. If you raise the head of the bed, that means you're bending the thoracic and lumbar already. Okay, so they should be. What if the patient has trouble breathing? What position is acceptable? Reverse Trendelenburg. Okay, so reverse Trendelenburg.
But you can't sit them up.
So these are the principles. So no part of the body must be twisted or turned. Okay, the patient must remain flat. Must remain flat. Again, if you need to raise the head of the bed due to breathing concerns, reverse Trendelenburg is acceptable. So this is how you answer what will be the patient's limitation so that we realistically impose activity restrictions. So we don't expect the patient to do certain things based on their level of injury. Expectations would also be good for the family members and the patients because they may have unrealistic expectations, especially when it comes to rehab. As to, let's say, they say, oh, I'm going to walk again. Well, it depends on your level of injury, okay? So that we don't have any frustrations or any conflicts within the family, relationships, okay? So C1, highest level of spinal cord injury, absolutely no activity. Patient will be dependent with almost everything. With dressing, eating, they can't do anything because they can't move anything below the neck. C2, 3, same thing, okay, very limited. In fact, with breathing, here the patient will have, because there's no diaphragm control, so therefore the patient will be on a vent. Same thing with C2, C3, but the patient may still require mechanical ventilation for short periods, but probably not 24/7. Maybe they can be off of the ventilator or during the day for short periods, but definitely at night they will be on a vent. C4, they have good head and neck control, so therefore they're able to use a call bell. A call bell, of course, will have to be modified to be activated with a straw. Okay, so they will simply blow into the straw to activate the button, so they can use PCA, they can use a call light, okay? So here they can even operate a wheelchair. Again, needs adaptation that the wheelchair will be operated with a straw, okay? Or anything they can push the buttons with, because they have good head movement. C5, even better head control. There's some shoulder strength, elbow flexion, so they can use a manual wheelchair, okay? With some modifications, of course. C6, so they have some arm control, although the strength is not normal, it'll be weak. However, they can transfer relatively okay with C6. And C7, C8, they can operate a regular manual wheelchair, okay? They can wheel themselves around. And I won't read everything for you. So questions here will be, could be select all that apply. So I'll ask you, which of the following can a C7 SCI patient realistically do? Okay, and then select all that apply. So the principle here is, of course, if it's anything higher, so the higher you go, the lesser they can use, right? So if you prefer, you can use the spinal nerve chart. You can look it up online. You can see which spinal nerves exit at what level, and that will help you. For instance, how do we know whether the patient can be off of a ventilator or not? Well, where is the phrenic nerve? The phrenic nerve controls the diaphragm. So therefore, which patient can be off of a ventilator? Okay, so it's right around C4. Okay, so C4, they can now independently breathe. Okay, no need of a ventilator. Does that make sense? Okay. And then also take note of, this is a good addition. The mobility part here is updated considering technology nowadays that we do have because of ADA, the Americans with Disabilities Act. So most companies have obligations to make certain equipment adaptable to Americans with disabilities. Okay, so that's why beyond the ramps for every building, for instance, especially federal buildings, most private buildings comply also because let's say New York City code requires it. Okay, for every new construction at least. Okay, let's go with the medications now. So after the injury, so this will be within the first 24 hours of the injury. Our concern again are the acute complications related to breathing. As far as steroids, the first statement here tells you everything about steroids. Long ago during my time, we gave steroids during the acute episode. Right now, there's really a big debate about the benefits of giving steroids during the first 24 hours. And here's the statement also for the same author. It's not really used widely. Okay. If the hospital chooses to, but really there's no, what they're saying is there's really no evidence of benefit to the spinal cord injury patient, meaning it doesn't show that steroids would facilitate recovery or prevent new or any complications. Okay. So this is part of the AB part, so airway and breathing. So you support as needed. If needed, the patient will be on a ventilator or at least a BiPAP, for instance, if the respiratory effort, because this can lead to respiratory failure. We'll discuss respiratory failure during the last hour today. We look for other injuries. So if there are displaced fractures of the vertebrae, then that will require traction. Traction would be, of course, applied to the head. So this will involve halo traction, so skeletal traction to keep the spine aligned and immobilized. Still remember how to take care of patients with external fixators, external traction, skeletal traction, because your concern really is the screws, right? Because we have the external fixator device is always applied outside and then it is drilled into the bone. In this particular example, is this drilled into the skull. So it is invasive, so therefore we take care of the pin sites every shift. There'll be a full discussion on the plan of care for patients with halo traction, because these patients are sent home with the device. So here's the halo. It'll be discussed more toward the end of the chapter. Oh, here it is now. It's not that far. So this is what a halo device looks like. So this is a form of external fixation drilled into the skull. And this vest right here has a sheepskin lining. It is, of course, worn over clothing to prevent irritation. However, no matter how you look at it, it looks hot, right? So imagine wearing this in the summer. They are allowed to take it off for about an hour for hygiene purposes. But when they take it off, the patient must be wearing a rigid cervical collar. The screws are, I mean, the bolts. Oh no, yeah, they're screws. Okay, so the screws are specific. So the wrench used to unhook it for emergencies, let's say you need to do CPR on the patient, it's always attached to the back of the vest. So if you need to take it off, just look in the back because it's always attached there. So you can quickly remove it and unscrew the the bolts, and then you can remove it for emergency purposes. We won't discuss surgery because anyway, your responsibility is pre and post-op care plus wound care. As far as orthopedic surgeries, in this particular instance, this is still involving bone, correct? So the dressings used here, just like with hips and knees, is long-term type dressings, meaning they have 7-day dressings, 14-day dressings. There's not much we can do, but just make sure the integrity of the dressing is maintained. Spinal surgeries do have a lot of drainage, so it's not uncommon for patients to have a drain after the surgery. So it's typically, if not a JP, they'll require a larger, like a hemovac, for instance, will be used because they bleed a lot. There seems to be a lot of drainage with spinal cord, with vertebral surgeries. Doesn't matter whether it's fusion surgeries or decompression spine surgeries. They have a lot of drainage. Typically around the 7th or 10 days. Now, because the drain is not part of the main dressing. So let's say you have a dressing, right? So this is my back, and I have the incision here, or let's say 2 incisions here. So the 7-day dressings will be on here, but the drain is always outside. Okay, the drain is exited away from the main incision dressing. So it's not like you have to take off the dressing to access the drain. Okay, so the drain is placed on another spot. Okay, there are 2 sets of complications: spinal and neurogenic shock. The true shock here is the neurogenic shock. We already discussed this last week. How do you recognize neurogenic shock? And we had a little trivia for this one. This is the only shock that has what? Bradycardia. Very good. Because this is a type of distributive shock, right? So this is along the same lines with septic anaphylactic shock. So there's vasodilation here because of loss of sympathetic tone. So instead, we have parasympathetic, which explains why there's bradycardia and vasodilation. So we discussed that. Let's talk about spinal shock. Just to make sure you still remember neurogenic shock. So what are the signs and symptoms? How do you know the patient? And this occurs during the first 48 hours. Besides bradycardia, what will happen? Where is the sweating though? Above or below the injury?
Above. No, I don't know.
That's okay. We'll discuss that later when we get to autonomic dysreflection. So what happens to the breathing here? Breathing will be shallow, right? So patient goes into respiratory failure. And of course, the blood pressure drops. Okay. Correct. So spinal shock is not shock per se. Okay, they call it spinal shock, but it has nothing to do with cardiovascular symptoms. Okay, no cardiovascular symptoms whatsoever. Spinal shock is a temporary sudden depression of reflex activity, also called areflexia, meaning the patient is paralyzed. So there's loss of sensory motor functions below the level of injury. The good thing about it is it's temporary. So this is not the same as the chart I told you to skip earlier, where there has central cord syndromes, etc. This one is temporary. However, we don't know when it resolves. The doctor can't tell either. So it's all about, if you, who has watched the season 3 of Cobra Kai? Remember when Miguel fell because they had that love triangle and they had a fight at the cafeteria, and he fell and and hit the railing. For those who don't know what we're talking about, a teenager fell from the second floor, okay, and hit his spine on the railing of the stairs, and then he became paralyzed. Right. But his paralysis wasn't permanent. However, at the time, the doctor said, we don't know whether or not he will recover, because we can't tell whether it's spinal shock or a permanent paralysis. Yeah, so that means he suffered spinal shock. Because again, the period can be as short as 48 hours, and then the sensory motor reflexes return. In his case, it was several months, correct? So it could be that. It could be a few hours or could be several months before it returns. Okay. Of course, rehab will help facilitate it. And together with these, again, depending on the level of spinal cord injury, if you look under the table 63-3 again, if you look under bowel and bladder control, right, should be somewhere here, right here. So sacral has normal to impaired bowel and bladder function, meaning can these patients pee or poop on demand? They will have to perform straight catheterization. Okay, so they'll have to self-cath at least 2 or 3 times a day in order to empty their their bladder. And for the bowel, they may have to take fiber, stool, softeners, or even laxatives in order to facilitate BMs. Or never fails, the just glove up and get in there.
Themselves.
Depends on their situation. They can do it themselves, or that's where you come in. You had to ask, Atuna. So yeah, that's the answer. That's where you come in. As with any other patients with mobility issues, so we were concerned with not only constipation, but pressure injuries, DVTs, same thing. So I won't go into detail with that. And you know this, right? You learned about DVTs in MedSurg 1. Okay, so if you suspect, then do not massage the leg. We'll talk about the other complication shortly, especially autonomic dysreflexia. For nursing care, please read the details on how to promote bowel and bladder emptying. This one's practical. Okay, airway breathing. There's nothing new here. You already know what to do. Suction, oxygen, breathing techniques. With mobility, this would be from active as far as they are able, mostly passive range of motion. The passive range of motion here can be done by the patient themselves, because depending again on the level of injury. So if they have any high thoracic, then they can move their arms, correct? So they can perform passive ROM on their legs. And these are again for pressure injury prevention. Okay, here's the bowel and bladder management. Because they have to do self-catheterization, or if it's as high cervical, that means a caregiver has to do the intermittent catheterization. So you have to institute CAUTI. Okay. We discussed CAUTI on the last module last semester. Okay. Okay. Most spinal cord injury patients, cervical to high cervical, will of course have a neurogenic bladder. That means the bladder does not contract at all. So because the brain innervation, the spinal nerve supplying the bladder is affected, so the bladder no longer contracts. The patient will therefore need perpetual self-catheterization or Foley, whatever the patient's condition situation is. They're in long-term care, most likely they'll have indwelling catheter. If they're at home, they can do with self-catheterization. If the patient is able to urinate, meaning they have lower thoracic injury, then bowel and bladder function may be intact. However, they have no control over it, meaning they are incontinent. So you can use external catheters. And this is for the bowels. All right, let's go with the halo vest. So I mentioned about the wrench or the screwdriver, which is again attached to the back of the vest should you ever need it. And here's your pin site care. So the skin under the halo vest is always inspected for any breakdown. Remember, 23 hours the patient wears the vest, so it can be prone to irritation and injury, pressure injury specifically. If it becomes wet, then the dampness does cause excoriation, especially in the summer. These things can be very hot. Do not use powder, or do not stick anything underneath there, just like you would not for patients who have a cast, for instance. So same principles, do not stick anything in there. We have an entire chart. Let me go to the chart and then I'll go back to autonomic dysreflexia. Okay, so here you go. The chart 63-8, page 207, just the next page, 2079. For skin care, the wound care, I mean, you use, I don't know if this, okay, no more peroxide. So this particular author do not mention the peroxide anymore. It used to be we use cotton tip applicators with peroxide to clean the pin sites. For here, we just use saline. So just rinse it with saline. Make sure you have gauze to catch as you rinse the pin sites. All you do is put betadine ointment around each site. Of course, you use sterile cotton applicators, and then just wrap them with dry gauze. Okay, any dry Curlex or piece of gauze, unwrap it, and then wrap it around um, the pin sites. Okay. Autonomic dysreflexia does not occur within the acute episode. This occurs later. So either several days to forever. Again, several days later to forever. So these are going to happen to patients who have a SCI of above T6, meaning a high thoracic injury. So are these quadri or paraplegics?
What you saying? Para.
Para and especially tetraplegics as well, or quadriplegics. So T6 or higher injuries, okay, experience autonomic dysreflexia. So this will not apply if your injury is T7 or lower. Are we clear? Okay, so this only affects people with T6, above T6 SCIs. What does this involve? So this is a hypertensive emergency. So what happens is the patient, it's life-threatening. What happens is they experience an exaggerated autonomic responses, specifically sympathetic response. Now, the patient, the triggers here are, no, those are signs and symptoms. The trigger here is usually something painful, such as a full bladder. A full bladder, is that painful?
Yeah.
Severe fecal impaction or constipation, is that painful?
So it would trigger.
A wound. Because the problem is, can they feel when they're constipated
No.
or when their bladder is full? No. T6 or higher, they can't feel anything. So therefore, plus they have no bowel and bladder control. So are they at risk for this?
Yeah.
Yes. Just because they can't feel it doesn't mean it's not happening, correct? So as the bladder distends or the bowel is severely impacted or they have a serious pressure ulcer, for instance, because even though they can't feel it, doesn't mean there's no pain, correct? So if so these noxious stimuli, not only that, because they can't feel anything below the bladder, no, below the umbilicus, can they feel when they're sitting on their testicles?
No.
Can they feel when they have a painful UTI, for instance, something like that? Or let's say they still have sex. These people can still have an erection through reflex, okay, not by, not by on command. The patient can still have an erection through reflex stimulation. Okay, let's say stroking the penis, um, with a lot of work. Okay, so they can still achieve an erection, so therefore they can have sex and they can have ejaculation. But if there is any sensation that stimulates sympathetic activity, is sympathetic system stimulated during ejaculation or during sex? Yes. So anything again that stimulates the sympathetic nervous system can cause autonomic dysreflexia. The two most common causes, however, is a full bladder or a impacted bowel. How do we know it's happening? The patient manifests the following: severe headache with paroxysmal hypertension. Blood pressure here would be over 200 systolic. Profuse diaphoresis above the injury, meaning if they have T6, above T6, so they'll be above the umbilicus, they'll have sweating here, but then the lower part of the body would be completely dry. They'll also have goosebumps above the level of all part of sympathetic stimulation, but none below. And of course, there's bradycardia here. Same thing as neurogenic shock. Other symptoms are nasal and congestion and nausea. And of course, the bradycardia. So these are the manifestations. So the first thing you would do is what? Check the cause, because the only way to stop this is to eliminate the cause. So what are the two most common causes again? Bladder distension and or bowel impaction. So I've only seen this happen once on a diabetic paraplegic. And he had all the manifestations, right? In his case, he was in DKA. He's diabetic because I guess he partied too much and drink beer, but then he was only self-cathing himself twice a day. And although that was okay, but during hospitalization, we were giving him fluids because that's how you handle DKA, correct? You give them lots of fluids, and then when his AKI, yeah, so when he went into the diuretic phase of AKI, yeah, we were still doing it twice a day. So of course, it led to the bowel distension. Okay, so we had this life-threatening emergency happen, and I was lucky it was the bladder. What if it was the bowel?
Give
Yes, I would have had to, no, laxative will not.
enema?
Yeah. You had to do that. But anyway, so the other causes are listed here. So I mentioned a few of them. A UTI can also stimulate it. Okay, ejaculation, a pressure injury. Because they can't feel anything, will they feel it if you, let's say, left a injection cap on the bed and they're sitting on it and it's digging under the skin? Or they were drinking water and it dropped a bottle cap and bottle cap is right there on their buttock, digging into the skin. So things can happen. Okay, so make sure you guys take care of the
So,
ways this can be stimulated. Okay,
so is it just stimulated by stress, basically?
anything painful, anything that will trigger sympathetic response. And these are your actions. First action, which is not different from eclampsia and hypertensive crisis or malignant hypertension, is to raise the patient's head of the bed up or put them in a sitting position.
Even with the spinal cord injury?
Well, again, when does this occur?
Oh,
This never occurs during the acute episode. This is later.
Later on.
Yeah, so like a week or beyond.
They're
Okay,
able to
and
mobilize.
yeah, and once they have it, are they immune?
No, they haven't yet.
This will be forever. Okay, so because they have above T6 injury, so they are prone to autonomic dysreflection. So first action is, as soon as you identify blood pressure is so high, you have the headache, the diaphoresis, the bradycardia, first thing you do is sit them up, and then look for, next action is to look for the trigger. So find the trigger. Again, the two most common is are bowel or bladder distension, and eliminate it. So if you see it's a bladder, straight cath, or some doctors will say, okay, put in a Foley. Here's the other one. Check the bowel, the bladder, and then the bowel, then check the skin, all the possible triggers. Okay, check for any injury to the skin, anything tight also, because sometimes, let's say you yeah, anything painful. Okay, usually the elimination of the trigger starts dropping the blood pressure. However, if the blood pressure remains high, then the patient must be given IV antihypertensives. So same thing as with stroke, labetalol, nicardipine, any IV antihypertensive. The patient also is monitored neurologically, because what could they develop? The blood pressure of over 200. Okay, so perform neurologic assessment as well. That's about it. Any question on autonomic dysreflection? That's it for spinal cord injury.